Hi, and welcome to your PMP My Pod video podcast. This is the only podiatry podcast that will help you succeed in your final podiatry class while also giving you pointers for success in clinics. I'm your host, Jared Shapiro. Hi again. Okay, so this week we're going to cover hindfoot and ankle trauma and a little bit of other stuff in addition to that. So let's start off with a little bit of housekeeping. Let's get the elephant in the room out of the way. And as I heard, your first quiz was not particularly successful. I guess the class average was about 65%. That tells me, especially considering that I gave you the topics for the quiz, that you probably didn't get a chance to study much. So again, I'll just suggest that you study as much as you can, a little bit at a time, and try to keep up with the slides, the presentations, and let's see if we can make that next score better. Luckily, you get to drop a few, so 4 of your 9 get dropped. Okay, let's have one more issue of to fix a small mistake that was made in lecture 5A.3. That's calcaneal fracture classifications, and there are currently 2 versions of both Bowler's angle and Gissane's angle. And in the Bowler's angle, they mentioned 2 different angle ranges. This one, as you can see, is 20 to 45, and then they also mention 25 to 40. So originally, Bowler in his article described that this angle that he found was actually 30 to 35 degrees. So it is common in today's kind of modern day medicine that people quote 20 to 40 as your normal. So for the class, normal is going to be 20 to 40. If you were to quote 30 to 35, that's totally fine. You can show how well read you are by having read or looked at Bowler's original article. If anyone's dying to read it, let me know, and I will send you the original copy. Okay, here's my pick of the week, and I went with books last week, and I'm going to stick with that theme just for this week. So there's a new textbook written by Doug Ritchie. He's a podiatrist who recently retired a couple of years ago. He's a very well-known and very well-respected podiatrist in the field, and he wrote this new book called Pathomechanics of Common Foot Disorders. Now, students are always asking me, where do I find out information about biomechanics? This, by the way, has nothing to do with this class, but it's a new book, so I thought you should know about it. So Pathomechanics of Common Foot Disorders covers the main concepts of modern evidence-based biomechanics. It's incredibly well researched and well cited. It gives you really good explanations. It covers foundational principles and anatomy. It covers medial column pathology. It covers the important contribution of the lateral column of the foot as a stabilizing structure to help the medial column become stable. So really good explanations for that. It will help you with your decision making later. It talks about hallux valgus disorders, hallux limitus, hallux rigidus, hammer toes, metatarsalgia, the insignificance of metatarsal length. So you might have remembered learning in PMP2 that the length of the metatarsal was important for lesser MPJ problems. It's not. So you'll understand why if you read his book. He covers adult acquired flat foot, also called posterior tibial tendon dysfunction, and he covers heel pain. So all really good stuff, and it will absolutely help you understand a lot better your biomechanics. Okay, so what am I musing about this week? Well, I wanted to talk with you about board studying. I've had a few students ask me about how they might study for boards. I know it's a little early, it's January, but there's nothing wrong with starting early. Do you have to start early? No. Anything after March I would consider late. So there's nothing wrong with getting a good start. So when you're studying in general, my suggestion is not to try to reteach yourself anything that you learned in your classes. You've learned those things. You've been tested. You know your knowledge is good. What you really want to do is uh, take quiz questions, Anki deck, all those types of things that have pre-structured questions, and test yourself. And when you know something, move on. When you don't know something, go back and look that particular topic up so you can learn that better instead of just randomly going and studying like gross anatomy or biomechanics. Just test yourself. If you know something, don't spend a lot of time studying it. Lower extremity anatomy always seems to come up as a question. Now, I know there are basically two primary sources that you can work with. One is the Scholl College PowerPoints, and the other is the Hirsch manual. Now, I'm a little older than you, and I like the Hirsch manual a lot, but I know your class doesn't love it. It's not particularly colorful. It's kind of dry. It's not the most engaging method, but it has all of the information that you could possibly need to do well in lower extremity anatomy. And what I can tell you from my own personal experience is that students who studied only the Scholl PowerPoints and just looked at them and kind of passively read from them, they were more likely to fail that section than students who looked at the Hirsch manual. So my suggestion when you're studying for anatomy is to, instead of trying to read through the Hirsch book, which is passive and isn't going to get you the information you need, is to open the book to the back. The back has a large appendix full of questions, and the questions relate to sections within the textbook. So ask yourself the question. If you can answer it, then move on. You don't need to answer the any further information. You know what you know. If you don't know, which is more likely than not, considering that it's been a while since we've had low extremity anatomy, if you don't know that information, then you go to the section and guide your reading and your studying accordingly. Okay, then you start doing quiz questions and that type of thing. So that was how I would suggest studying for your lower extremity anatomy. There's nothing wrong with using the Scholl PowerPoints. They're not inaccurate. They're just very passive. And if you have quiz question banks that are created as a result of that, and you ask yourself those questions, then you're okay. So really, to me, the key is about quizzing. Okay, let's get right to the cases. Triplane fractures have come up on the first section that you had done already from pediatric fractures. But I wanted to go over this real quick just to make sure that you understand sort of what a triplane fracture really is. So a triplane fracture is a type of pediatric fracture, and it occurs when part of the growth plate is open and part of it has ossified. So this is usually somewhere between the 12 and 15-year-old age group that we tend to see it. And in this image, you can see these three views of this ankle. All of the entire growth plate appears to be open, but really it's starting to ossify. We just haven't seen it yet on the radiograph. So you have to remember that the sequence of ossification is important, especially as it pertains to triplane fractures. You'll remember that this starts in the anteromedial and medial area, and then the ossification sort of wraps around the posterior side and then finalizes at the lateral side where the entire growth plate is then ossified. So if that's the case, then the lateral kind of half or so of the growth plate is weaker. And if a 12 to 15-year-old who's starting to ossify this area, it doesn't have to be fully ossified, it just needs to be partially ossified. If that happens, then you'll create this three-dimensional kind of fracture. So on this radiograph, you can kind of see that this actually is a combination of a Salter-Harris 3 and a Salter-Harris 2. So look first on that mortise view on the far left. You can see that the fracture line runs into the joint longitudinally, and that's the Salter-Harris 3 part. Okay, but this fracture actually then bends, runs sort of in an anterior to posterior direction, and then slides up the back and out the posterior surface. And that part, if you look on the lateral, which is that most right side image, you can see that that is the Salter-Harris 2. So on a lateral, a triplane fracture looks like a Salter-Harris 2, and on a anterior-posterior view, the fracture looks like a Salter-Harris 3. So it's a combination of both of those. Okay, so this might help a little bit. This is the CT scan of the same patient. You can kind of see that fracture a little bit better. So the Salter-Harris 3 is on that coronal view on the CT scan on the left side, and then you can see on that sagittal, you can see that little piece coming out the back, that little triangle shaped piece, that is the Salter-Harris 2 part. So obviously for somebody like this, if you're going to fix this because it is a intra-articular fracture in a kid, and you want to try to get this anatomically reduced so the child doesn't end up with having ankle arthritis. So you remember one of the principles is not to cross the growth plate with anything that, if you can help it, but if you really have to, you can use a K-wire. But in this case, if you were to put a screw going from the medial malleolus all the way lateral to grab that piece of the lateral side of the epiphysis, you would be able to put a screw that runs transversely, and that would fixate that part of that together. Now, in this particular case, because the Salter-Harris 2 part of this fracture is so small, nobody would bother fixing that. That's too small. But in some cases, that fracture could be really large and exiting out the posterior surface, in which case you might then put a screw into that, or two, or a plate, depending on what you think. Okay, so that's triplane fracture. Now I wanted to show you a case that's relatively recent. One of my residents and one of our local attendings saw this patient who's about a 64-year-old lady who was snowboarding. She was sitting on her butt going down Mount Baldy in the snow and wanted to stop. So she put her foot out and slammed into a tree using her foot to stop herself. Not a particularly smart thing to do. So when she slammed into this, she created fractures of multiple bones. Now, you can see that there's an obvious oblique, minimally displaced but comminuted extra-articular fifth metatarsal fracture. And so that one's easy to see. But there's also a navicular fracture and a cuboid fracture. So her mid-tarsal joint got squished. It's called a nutcracker fracture, and she nutcrackered her foot. So you can see on the lateral, you can see that the navicular has a fractured piece that's off the top. Now, this piece is actually heavily comminuted. I'm going to show you the CT scan in a second. But if I were asking you to classify this fracture, this would be using a Watson-Jones classification. And it would look like a sort of fleck fracture off the top, so that would be like a Watson-Jones 2. But let's look at these other images. So what we have here, just to make sure that you're straight on the orientation, is the image on the left is a CT scan, and it's called a 3D reconstruction. So the computer takes all of the images, puts them together, and creates this really cool three-dimensional image that in many cases you can actually rotate the foot all over the place and give you a better view of the fracture. Now, you can see on this that the navicular is actually broken into 3 pieces. Both of those pieces run longitudinal in the foot. So you have one that's sort of central medial. There's another one that's central lateral, kind of lined up with the medial articular surface of the lateral cuneiform. So that navicular is in three pieces. And then it's a little hard to see in this, but the cuboid is also fractured. And that is fractured in reality, which you cannot see on these images. The cuboid is actually fractured and it has displaced dorsally. So in the central image, we're looking at a transverse view, an axial view, and you can see that navicular is in three pieces. Okay, so that's your navicular. So if I was asking you to classify that, then that would be considered a Watson-Jones 3B because it is a body fracture that is comminuted. So a 3A would be non-comminuted, and 3B is comminuted. If if I were to ask you which has the worst prognosis, the comminuted or the non-comminuted, I think it'd be obvious that you'd like to have the non-comminuted fracture. Now, on the longitudinal or sagittal view, that's the one on the right, you can also see that this fracture is the way that it's broken. So it wasn't fractured just longitudinal ones. There's also fractures running in the transverse direction, heavily comminuted. That's what I would suggest to you. And what's unfortunate is that this is not a joint in the body that you want to break. The talonavicular joint is considered an essential joint. It's a very important joint to maintain mobility of the hindfoot. So if this patient ends up either needing a primary fusion, or if she ends up having arthritis later, she may need that fusion, and that's going to make her foot much more rigid and less functional. Okay, so as a little show and tell, this was what was done. So one of my clinical partners in the area and one of the residents, they fixed the fifth metatarsal fracture mostly. It was heavily comminuted, and they used a special kind of plate, which is a very small metatarsal locking plate, and at the distal end of the plate, it has what looks like an upside down U. And what that does is it grasps the medial and lateral sides of the metatarsal and sort of holds that together because of how heavily comminuted it was. So I could tell that that's a locking plate because the two screws proximally, the heads of those screws are embedded inside of the plate, as well as the distal most screw is embedded in the plate itself. The third screw is actually not a locking screw. It's a screw that they ran to try to compress some of that fracture together. And then you can see on the medial side, that is a monorail mini external fixator. So you can see in the clinical image that pink color. So that is made out of some radiolucent material, which is why you can see that the part of it looks like a light colored gray, and then the other part's dark, where it's titanium. So the reason for that external fixator is that this patient had too much edema for them to be able to do a primary open reduction and internal fixation. But they also needed to try to get the length back out and decompress the navicular as much as they could. So they put the external fixator on in the neck of the talus and into the medial cuneiform, and then they distract it apart to try to pull some of that navicular apart and give it the chance to not necessarily heal right away, because in about a week after the surgery, they would be bringing this patient back for a definitive open reduction internal fixation. Okay, moving on now to talar neck fractures. I just wanted to go quickly over the Hawkins classification. Remember that Hawkins is just for talar neck fractures, which is what you can see on the image on the left. And the Hawkins 1 is what I would suggest to you is the image on the right. So it's very hard to see, but the talar neck had cracked and displaced just very slightly, and then it healed. So this is kind of an old fracture, and this patient actually got really lucky because it didn't displace as much as the one on the left did. So a Hawkins 1 is just a talar neck fracture that has non-displaced. A Hawkins 2 is where the subtalar joint dislocates, which is exactly what's happened in the image on the left. A Hawkins 3 is where the ankle joint dislocates, and you can see in that left image that the body of the talus is and the talar dome is articulating with the ankle, so that has not displaced. And so what you're seeing right now is a Hawkins 2 fracture. And then in the worst case scenario, the talar navicular joint would have displaced. That would be a Hawkins 4. And each of the Hawkins numbers is worse. So 1 is better than a 2, is better than a 3, and is better than a 4. So the reason that they're bad, obviously, is that you're getting more displacement. And if you do that, then you're going to damage the vascular structures and increase your risk for avascular necrosis. So outside of a Hawkins 1 and maybe a 2, depending on how much velocity there was, this patient's almost guaranteed to have a talar avascular necrosis of the talus. Okay. Now, during the open reduction internal fixation of the talar fracture, there is a radiographic view that you obtain, and I want you to know, what this view is. It's called the Canali and Kelly view, and you can see on the image that you've pronated or everted the foot about 15 degrees, and then you angle the radiograph, the X-ray beam, about at 75 degrees to the foot. And when you do that, you come up with an image that looks something like this. Now, what you're seeing, what you're really looking at, is the medial column. So you want to see how the talar neck aligns with the rest of the body, and also how it aligns with the navicular and the kind of the medial arch. The reason for that is that if it's very common when fixing talar neck fractures to accidentally rotate the head and neck of the talus into a varus position. And if you do that, you'll cause the patient to have a forefoot varus. That's not a deformity that you want to create. So this view will help you determine whether or not your rotation is correct. A quick word on talar body fractures. So in this particular one, you can see that the talar body is fractured in two pieces, a medial and a lateral half. Definitely not a good situation. The Sneppen classification is the one that you're going to use to classify talar body fractures, and it's a little hard to see this one. We're going to say, for the sake of discussion, that this has just one clean fracture straight down the middle in a large kind of sagittal direction. That would be considered a Sneppen C. Now, to fix these is actually harder than fixing a talar neck fracture, in the sense that it's harder to get at the talar body. It's bigger, so it's easier to fix once you can get to it. But the trick is trying to get to it. Now, the way that is commonly done, or most likely to have to happen, is that you'll create a medial malleolar osteotomy. So some people will call this a medial malleolar cut down osteotomy. And it'll be kind of lined the way the line that I drew here. So what you'll do is you will put two drill holes for screws into the medial malleolus and running into the tibia before you actually make the cut. And the reason that you do that is that when you put this back, you want it as precise as you can. And so if you pre-drill the holes, when you put your screws in, they're going to go right in, nice and easy. So you put your screws in, you make the cut, and then you flap the medial malleolus distally. And when you do that, you have a good visual access into the talar body, and that helps you to fix the fracture. Okay, now we're going to move on to calcaneal fractures, and of course these are a little bit more complicated. So there's a little bit more on this. These two pictures here are to remind me that calcaneal fractures most commonly occur due to axial loads. More commonly in men, because men do some dumb things, but a lot of times men are in the construction industry or climbing up ladders. If you climb up a ladder, fall off the ladder, but land on your feet, you're more likely to create a calcaneal fracture. So I am petrified of ladders after having seen and fixed some calcaneal fractures. And so I try my best to stay off of ladders as much as I can. Clinically, there is this sign that I wanted to show you to make sure that you got a chance to actually see what this looks like. So you can see that there's ecchymosis both on the lateral side of the ankle in the top foot, but also on the medial arch. And that is called Mondor's sign, Mondor''S, Mondor's sign. You typically do not see bruising directly on the plantar calcaneus. You'll see it on the lateral side, but instead, because of the axial loads and because it is possible to bleed into a potential space, which is what the medial arch is, the blood will move into the medial arch with a calcaneal fracture, and you'll get Mondor's sign, which is what this is. So here's a lateral radiograph of a calcaneal fracture. Now, what most people might ask you, what radiographs should I order if I have a patient who I suspect a calcaneal fracture? It's pretty typical, given the fact that these patients oftentimes have multiple injuries, to order both foot radiographs and ankle radiographs. But with the foot, what really matters is the lateral and the calcaneal axial. So those are going to give you the majority of your calcaneal fractures. A medial oblique radiograph of the foot will let you see the anterior process of the calcaneus well. So sometimes that can be helpful. In addition, if you happen to have a fracture off of the plantar medial tubercle of the calcaneus, then a lateral oblique image will actually be good. So that would be something that you might order later. It's also possible to have other fractures like talar fractures, ankle fractures along with these, and so it's oftentimes necessary to double check and make sure that the patient doesn't have an ankle fracture, a pilon fracture, or something else. Additionally, when you're doing your workup of a patient with this, you have to make sure that they don't have other injuries above. So we would term them suprastructural injuries. It's common to injure the back, so the lumbar area, L1, is commonly affected, but you could see it along the lumbar spine. You might have vertebral fractures. You could injure the bladder. You could lacerate the spleen. So a full trauma survey is necessary in order to make sure that these patients don't have other associated life-threatening injuries. Now, the other part of this is about classifications, because God knows there's so many classifications for trauma. So on this lateral x-ray, I might ask you to classify this. And you have two classifications that are involved with radiographs, Rowe and Essex-Lopresti. So for Rowe, this is an intra-articular fracture that affects the body, but it's not comminuted. So I would call this a Rowe 4. If it were comminuted, like a joint depression fracture, which we'll see shortly, then that would be a Rowe 5. With Essex-Lopresti, this one is a little bit more difficult for us to actually answer the question, because Essex-Lopresti is either a tongue type or a joint depression fracture. And so a tongue type is oftentimes involved with, either the Achilles ripping a piece off or avulsing a piece off, or the superior posterior tuberosity being fractured. And in this case, that's really a body fracture that occurred. Um, and this one looks to me like it was the start of a joint depression fracture that, luckily for this patient, did not have a significant amount of velocity when the patient hit the floorboard in their motor vehicle accident. And so this looks a little bit more like a tongue type, but it's probably a very early joint depression fracture. So that's how I would classify those based off of what I'm seeing. Now, as for your information, this is how this patient was repaired. The patient was fixed with 2 compression screws, and you remember again we talked about AO principles, that we want to have rigid internal fixation, anatomic reduction, so that the patient can have early range of motion. So if we didn't have a good strong fixation here, then the Achilles would end up pulling on that superior fracture, and this patient would have trouble healing. So these were 2 compression screws, and if you think back to the questions that you've been asked about, types of screws, these would be lag by design because they're partially threaded screws. Okay, here is a CT scan of a completely different patient. And we use the Sanders classification most commonly for looking at calcaneal fractures with CT. So almost all calcaneal fractures, unless they're really simple looking, will end up with a CT scan. So with the Sanders classification, these could be somewhat hard to answer the question, what is the classification? But the first thing is you have to be able to see the posterior facet of the subtalar joint and the sustentaculum tali. If you can't see the sustentaculum tali, then there's no way that you can classify this using Sanders. So in this case, this looks like it has 3 pieces, but I'm going to show you that this actually just has 2 pieces. So there's 1, and then this is all the second piece. Okay, now that piece in between the 2 that looks like it might be its own 3rd piece, that's actually a piece of the body that just broke in addition to the sustentacular piece. So if that's the case, let's get rid of these. We have 2 fragments. That means it's a Sanders 2. And then where the major fracture line, again, that's going to be the line between the large, like thick piece in the posterior facet and then the sustentaculum piece. There's one fracture line that involves the posterior facet of the subtalar joint, and that's somewhere in the middle of the joint. It's not on the lateral side, and it's not in the sustentacular fragment. That means it's a B. So 2 pieces, Sanders 2. The fracture line goes through the middle of the posterior facet of the subtalar joint, so that's a B. So Sanders 2B. Now this piece right here, just in case to prevent you from getting confused, that is the lateral wall. And it's common that fractures, joint depression fractures, have lateral wall blowouts. And that lateral wall piece actually articulates with that first piece that we were just looking at, that kind of square piece of the posterior facet. So if things were brought back into proper alignment, that wall piece would articulate with that sort of central looking piece of the posterior facet. Now, on an entirely different case, I want you to take a look and see, evaluating the reduction and the fixation. Now, it's important to know that with calcaneal fractures, the outcomes tend to be better with as precise an anatomic reduction as you can get. So your goals are to uh, reduce the varus that exists naturally that happens with these joint depression calcaneal fractures, to get the length of the calcaneus back to normal, to make sure that you take care of the intra-articular fragments or fractures to try to get that posterior facet as articular as well aligned as you can get, and then to reduce the thickness or width of the body. Now you can see in this case that when we look at the calcaneal axial view, that's the one on the left. So we're looking at the calcaneus sort of from a posterior to anterior approach or view, and the pieces are not quite lined up well. So let me go over to the other side, because the way I have this thing set up, I want you to see that it might look pretty good on the lateral. So what you're looking at there is it's called the perimeter plate, and once everything has been fixed back together again, you have to hold everything together, and that's done with this plate. So some screws are put into the plate to hold it on, and that holds all of those fracture fragments together. And then we look at Bowler's angle. So there's the first line and the second line. And I checked this line, I measured it myself, and this measures 17 degrees. Now remember, the normal Bowler's angle was 30 to 35. So this still has a low Bowler's angle. And when you are doing surgery, you want to make sure that Bowler's angle is as like tall or large as you can get. It has to be within that 30 to 35 area. If you want to say 20 to 40, that's okay. But normal Bowler's angle corresponds to patients doing better post-op. Okay, so there's a problem there. That's low. That means that this is not anatomically reduced. So that is the lateral side the medial side of the calcaneus. And then there's another piece that's right there, and that's that's right underneath the subsentaculum tali. Well, those two pieces should actually line up together so that they show the length. So you can see that this is a short calcaneus. It needed to be brought out to length even further, and that's why Bowler's angle is not looking good. Also, if the piece on the bottom were not just brought back out to length, but also able to be brought somewhat more medial, then the whole heel would be thinner than it would have been the way that it's currently fixated. So this isn't properly reduced. Okay, so we want to move that down, like you literally would put a pin through that and you'll pull it down and move it over to try to get that back into proper alignment. Okay. With this one, this is a different case, and this one's not that impressive. Actually, this patient got kind of lucky. Their calcaneal fracture is not terrible. This would normally be treated non-surgically, but then you also notice that there's a navicular fracture. So take a look at that for a second, and you can see that the navicular tuberosity has been avulsed off. This would be, if I asked you to classify this, this would be a Watson-Jones type 1. Here's one more calcaneal fracture. You can see that this is additionally a Sanders 2, but this one's an A. So Sanders 2A. So if you look at the image on the bottom left, that one you can see a subsentaculum, and you can see a fracture line, that one single fracture line that goes from the posterior facet down. and it's a little bit more on the lateral side. So that's two pieces. Say there's two, and the fracture is further lateral, so that makes it a 2A. Okay, let's move on to ankle fractures now. Never want to have that. That's a posterior ankle dislocation. So a couple of things real quickly. When we're talking about fractures, you can have avulsions of pieces of bone, or you can have ruptures of ligaments when you're talking about these fractures. So if the anterior inferior tibiofibular ligament were to pull off a piece of the fibula, that piece is called the Wagstaff fracture. If, on the other hand, the piece of the anterior inferior tibiofibular ligament pulled off a piece of the tibia, then that is called the Toulouse-Chapeau fracture. Okay, so just two little extra fractures that you would kind of be watching out for. Okay, let's talk about classifications, because you're going to have to be expert at classifying ankle fractures, because you're going to get asked this question by more people than you're going to wish would. So I'm going to show you a method to do this so you can classify your fractures as well as you can. So the first thing is to know that you need to find the Dennis-Weber classification first. This one is purely based on where the fibula fracture is in relation to the ankle joint line. So the ankle joint line on this x-ray is indicated by the green arrow that cuts across the fibula. So if the fracture is below the level of the ankle joint, then that is a Dennis-Weber A. If it's at the level of the ankle joint, which means that the fracture starts at the level of the ankle joint, and what you're seeing here between the green line and the red line is considered the sort of the ankle joint line, and that includes where the fibula is articulating directly with the tibia. Then that's the incisura, so that's considered part of the ankle joint, and then everything above that is considered above. So Dennis-Weber A, Dennis-Weber B, or Dennis-Weber C. Now you'll need to know that in order to help you figure out the next classification, which is the Log-Hansen. Now you can just memorize this, and that's fine, but there is an easier way to do this. So if I have an ankle fracture and I'm trying to figure out what the Log-Hansen classification system is, first, if you haven't watched the video for this, stop this presentation and go watch it, because you're going to need to know this. I'm assuming here that you know some of this already. So the first thing is you're going to look at whatever fibular fracture is there. Okay, you're going to find your Dennis-Weber, and then based on your Dennis-Weber, that's going to help you figure out your Log-Hansen. So if your Dennis-Weber was A, which was below the level of the ankle joint, the only Log-Hansen fracture that it could be is a supination adduction, or SAD. Do not describe this as SAD. It's just SAD. If it is at the level of the ankle joint, which is a Dennis-Weber B, then you could only have an SER or a PAB, so supination external rotation or a pronation abduction. If it's a C, which is above the level of the ankle joint, then it is a PER. Okay, so you can start to narrow down which of your Log-Hansen classifications you have based on simply knowing your Dennis-Weber classification. Okay, then you're going to look at your medial malleolus and your clear space to look for other fractures or displacement of the ankle joint. You'll then choose the Log-Hansen number based on what you're seeing on the fractures. So, like, for example, SAD only has 2 numbers, so an SAD1 or an SAD2. The SER has 4, the PAB has 3, the PER has 4, and you're going to have to know those as well. So you'll figure those out based on memorizing the sort of clockwork appearance of those involved structures. And for that, I'm going to suggest that you refer back to your lecture on classifying ankle fractures. Okay, so here's an example of an ankle fracture. You can see that there are actually two fractures. There's one on the fibula and there's one on the medial malleolus. So this would be termed a bimalleolar ankle fracture. A unimalleolar fracture would just simply be one, and a trimalleolar would include the posterior facet. The posterior malleolus of the tibia. So first, I want you to see, where does this ankle fracture start? So let's look at the fibula, and the fracture is right there with that red line. That's right at the level of the ankle joint. So that automatically makes this a Danis-Weber B. Okay, so now I need to know my log Hansen. So if this is a Danis-Weber B, that means it can only be a supination external rotation, or SER, or a pronation abduction, or PAB. Now this fracture also has a posterior spike, and you have to look at the lateral radiograph to see this. So the fracture on the anterior posterior view looks like it's just this slight little curving fracture, but that is not true. Look at this instead, where I outline. This is actually the shape of the fracture. Okay, it takes a little bit of practice to see that, because you have to, look past the tibia in order to see where the fibula fracture is. So this fibula fracture starts at the level of the ankle joint. It is a spiral oblique shape. That's the curve upwards, and it has a posterior spike. Okay, the only one of the two, the SER versus the PAB, that has a spiral oblique fracture with a posterior spike is an SER type of fracture. Okay, so now we know this is a Danis-Weber B. This is an SER. Now, if it's an SER, then I think about the steps. So the first step of an SER is going to be rupture of the anterior inferior tib fib ligament, or a Wagstaff fracture, which I don't see, or a Toulouse-Chapeau fracture, which again we don't see. So that means the AITFL had to be ruptured. The second step in that, going in a sort of clockwork direction, would be the fibula fracture. That's SER2. SER3 would be a posterior malleolar fracture. I'm going to get rid of these lines here. So a posterior malleolar fracture, which I do not see, or a rupture of the posterior inferior tibiofibular ligament. And I can't tell that on an x-ray. That's not possible to see that. So I don't see a posterior malleolar fracture. Okay, so I'm not sure yet which one of those could it be. It's not a posterior malleolar fracture. Could it be rupture of the posterior inferior tib fib ligament? Yes, because I can't see it on an x-ray anyway. And then, my last step, the medial malleolar fracture. So that means this has to be an SER4. Okay, so here's a hint. If you see a spiral oblique fracture that starts at the level of the, if you see a spiral oblique fracture of the fibula that starts at the level of the ankle joint, and you see a medial malleolar fracture, the patient has to have an SER4 fracture, period, always, at least according to log Hansen. Okay, here's another one. Different patient entirely. So this one also has a fracture of the fibula that starts at the level of the ankle joint. And then this one also curves up. If you look at that really poor lateral, that's actually more like a mortise view, but that's supposed to be this patient's lateral. Don't ask why it's such a terrible lateral. I have no good explanation for you. But you can see that the piece runs back up, so that is spiral oblique. Okay, so this patient has a fracture of the fibula that starts at the level of the ankle joint. Again, that's Danis-Weber B. That means this can only be an SER or a PAB. If this has a spiral oblique fracture of the fibula, that means it has to be an SER, because a PAB would actually have been a straight fracture with the spike on the lateral side. That would be a PAB, but we don't see that. So again, I see a medial malleolar fracture also, which means that this is an SER4. So if I were to ask you on a test, here comes a giant hint, if I were to ask you on a test what soft tissue structures were damaged, according to the Log-Hansen classification, there are two answers, an AITFL and the PITFL, because those were the two soft tissue structures that had to do with the SCR1 stage and the SCR3 stage. Okay, let's move on and sort of finish things off, get to the end here with the Rudy Allgauer classification for pilon fractures, because that's what this is. This one is a very unfortunate patient. If you're going to have a fracture, this is the last fracture you want to have. Pilon fractures have very poor prognoses overall. So again, axial load for most of these. If I asked you what classification this would be, you would say that this is a Rudy Allgauer, so that's your classification system that you'd use. And it is fractured, as you can see. It's comminuted in several pieces, but it's mildly to moderately displaced. It's not totally displaced, it's just mild to moderate, and that's like mid-range. So the Rudy Allgauer classification is actually pretty easy, right? It's a 1, which is fractured but non-displaced, 2, which is fractured and mildly displaced, and 3, which is fractured and severely displaced. So that makes this one an Rudy Allgauer 2, and this is just about on the borderline of the Rudy Allgauer 3, because when you look at that mortise view, it looks like it's pretty heavily comminuted, and it could, any minute, it's just going to move more. But we're going to call this one a 2. Okay, now I can't but help to mention a couple of principles involved with this. Now, I've mentioned before about the soft tissue envelope, and the pilon fractures are one of the main areas where it's really important that you wait before opening the skin to fix this, because you have a damaged soft tissue envelope. The damage to the tissue around the ankle is a lot worse than you might think. So we have found that when you temporarily fixate these, reduce them as well as you can, and then allow a little bit of time before you do your actual open reduction internal fixation, that the patients do better. Because the skin over the anterior leg, if that opens up and you have a dehiscence or an infection, they can end up with a below-the-knee amputation very quickly. So you temporarily fixate this with the device that you see. This is called a delta frame. It's called a pin-to-bar fixation. So there's a pin that goes through the calcaneus. There are 2 pins that are in the tibia, and then those bars attach very quickly to those little clamps. They're called quick connect clamps, and this can go on very quickly. So you put this on, you distract and pull the leg distally, you try to realign as much of this as you can without damaging the patient, and then you lock it all down, tighten it up, and you wait a week or 10 days before you go in and fix this. Now, one of the things that is important is to remember that the place where you put your pins has to be far enough proximal on the leg that it's not going to get in the way of your incision when you actually do your fixation. So generally, you want it a little bit more proximal than what's shown in this image. The incision for this very commonly looks something like this. So this is called an anterior extensile incision and it allows full access to the anterior ankle and the leg, and it lets you see things a lot better when you're doing the reconstruction. Okay, now this is what this person's reconstruction looked like. This was actually done by one of my clinical colleagues at a Kaiser in the Central Valley, California. So you can see that there is a screw in the medial malleolus, which is kind of pulling the medial malleolus to the tibia. And then there's a plate that goes, this L-shaped plate that's on the anterior part of the tibia, and this is holding the ankle joint and the tibial bones together while they heal. So we have a nice anatomic reduction. The ankle joint is better. It's not great, but it's better. And this is a much more rectus appearance. So this is a relatively successful fixation construct. Okay, so let's finish this up. What I'd like to ask you to do is to keep studying as you go. Don't leave this for the last minute. I think you might be starting to see that this material is not the easiest material to pick up at the last minute. This is not something to cram. Look at those classifications, memorize them as much as you can, and let me know if you have any questions. Okay, and on that note, I wish you a good day, and I hope everything goes well. Please feel free to let me know if you have any questions. You can either put comments into Elentra, you can email me, or you can put questions in the Q&A section on the YouTube video. Have a good night.